Good
Today my
evening.
topic is nutrition care in a 67-year-old CVA patient on RT feed. It's enteral feeding.
Yeah.
Coming to overview of my topic, I will proceed with the introduction, nutritional assessment of the patient, creating a feeding regimen, and initiating the tube feeding, and finally complications of enteral feeding. Coming to the introduction. Malnutrition, called undernutrition, is a state in which a deficiency either of total energy or of protein or other nutrients leads to a reduction in body cell mass or organ dysfunction. The fundamental goal of nutritional support is to provide the daily nutrient and energy needs of each patient and to treat both macro and micronutrient deficiency. The aim of nutritional support in ICU is to attenuate the detrimental effects of clinical illness on nutritional state, such as increased energy deficit, and the patient are in catabolic state, not only due to disease itself, but also what we do and what we give, that is medication. The patient will be in stress, increased adrenal surge, increased insulin requirement, and especially these patients, CVA patients, may be on prolonged bedridden with muscle wasting, and they may complain of dysphagia also. Currently, it is unknown how long starvation in critical illness can last without harmful consequences. But most guidelines agree that nutritional therapy should be started as soon as possible, certainly within the first week of critical illness, ideally within the 48 hours. In comparison with malnutrition associated with starvation, which is due to depletion of essential nutrients only, the malnutrition associated with critical illness, which is seen in ICU, is the result of abnormal nutrient processing also. So, goal is not only to provide nutrition, but also to resolve the metabolic derangement. Coming to the nutritional assessment of the patient. Patient admitted to ICU should be quickly assessed regarding nutritional status of that patient. There are so many tools such as MUST, ESPON, that is American Society of Critical Care Medicine, and so many things. But most recently, ESPON, that is European Society for Clinical Nutrition and Metabolism, they have described a guidelines which is more or less more recommended. The approach is clinical bedside examination, which includes pre-admission ICU, any weight loss over, whether it is an acute means over 2 weeks, whether there is any chronic weight loss over 6 months. So we should take, if possible, pre-admission ICU weight loss and ask for there is any change in food intake, or in CVA patient the history of prolonged bedridden, and whether the patient requires anybody to feed, and ask for any GIT symptoms like nausea, vomiting, diarrhea, anorexia, and functional impairment. This history should be combined with physical examination, and it includes first and foremost oral hygiene, especially the patient with history of CVA may have difficulty in feeding, and these patients depend on others for feeding, and look for any toothache, tongue color, which all depends upon the presenting clinical condition. Whether the patient is intubated, consciousness, obeying commands, or drowsy. Look for any loss of subcutaneous fat over the chest and triceps. Look for any muscle wastings over the temporal area, deltoid, and look for thin turgor, whether scaly. It may indicate a micronutrient, that is selenium deficiency, and look for there is any signs of edema or ascites. This is all called as subjective global assessment. However, practically speaking, especially in busy ICU, these tools are very difficult to measure. So most of the time, the patient may require around 25 to 35 kilocalorie per kg per day of energy required. Most important thing is patient should be regularly reassessed regarding nutritional intake and progression, especially by if available by dietitian or nutrition specialist. There is an equation described by Harris Benedict which uses some formulas in males and female patients to calculate the basal metabolic rate. By calculating in this equation, it gives the calorie requirement around 25 to 35 kilocalorie per kg per day in a afebrile individual. And it should be modified according to the situation. If there is any history of fever, increase by 10% for each 1 degree rise above the 37 degrees centigrade. Coming to the third category, creating a feeding regimen. Careful balance of macronutrients, that is protein, lipids, carbohydrates, which provides the energy requirement, while micronutrients, that is trace elements, includes vitamins and minerals, are required in very small amounts to maintain health, immunity, but they don't provide any energy requirement. So macro and the micronutrients should be balancedly given. Creating a feeding regimen is a stepwise approach. It involves 4 steps. The first step is first you calculate the estimate the daily energy requirement and macronutrient requirement. For example, the total calorie requirement is 25 to 35 kilocalorie per day. So first calculate the body weight of the patient. If it is if actual body weight is ideal, for example, ideal body weight is more than 25%, then we'll go with ideal body weight. If it is actual body weight is more than 125%, we'll go with adjusted body weight. So adjusted body weight we'll calculate by measuring the actual body weight minus ideal body weight into 0.25 plus ideal body weight. So first you should calculate the body weight, and depending upon the range, we should take it as actual body weight or ideal body weight, adjusted body weight. Once we take the body weight, then we should calculate what is the calorie requirement. So as I already mentioned, the patient requires 25 to 35 kilocalorie per kg per day. For example, the present scenario gives 70 kg individual, and if you take 30 kilocalorie per kg per day, 30 into 70, it comes around 2100 ml of kilocalorie per day requirement is needed. So daily protein requirement is usually 1.2 to 1.5 gram per kg per day. So by calculating this in the 70 kg men, it comes around 80 gram per day. But all of us know that 1 gram of protein will give roughly 3.74 kilocalorie. So 80 into 4 comes to 350 kilocalories per day. So protein requirement out of 2100 comes to 350 kilocalories per day. When it comes to carbohydrate, remaining calorie, it should be given at the rate of 60% and lipid at the rate of 40%, which it corresponds to 1050 or 260 kilograms per day or 700 kilocalories per day. So by calculating with this formula, we can derive the equation. Second step is selecting the feeding formula. The feeding formulas are available with calorie density. So most commonly, the commercially prepared preparations are available at calorie density of 1 kilocalorie per ml or 1.5 kilocalorie per ml, 2 kilocalorie per ml. We most commonly use 1 kilocalorie per ml of artificial feed. So it provides for each ml, it provides 1 kilocalorie. So standing feeding formulas, they contain 35 to 40 grams per protein per liter, and it may include vitamins and trace elements. The vitamins includes most commonly thiamine and vitamin A, and the trace elements with selenium is an important antioxidant. Step 3 is calculate the desired infusion rate. First, you calculated the energy requirement. Next, you selected the feeding formula. Third, how you infuse the desired by enteral feeding. So, by calculate the volume of the feeding formula, thus must be infused to meet daily calorie requirement, which are divided by daily calorie requirement in kilocalorie per day of calorie density of that feeding formula. That is 2100 divided, if you take calorie density of 1 kilocalorie per ml, it comes around 2100 liter. So infusion rate in ml per hour is equal to feeding volume ml by feeding time in hours. One important consideration to be remembered is if any propofol is being infused for sedation, which is available as 10% lipid emulsion, which provides calorie of 1 kilocalorie per ml. That is 1 ml of propofol infusion may provide 1 kilocalorie. Then subtract the calorie provided by propofol from the daily calorie requirement. Step 4 is adjust protein intake. First, I should calculate what is the projected protein intake in grams per day. The formula is feeding volume in liters per day into protein feeding grams per day. So it should be protein should be adjusted depending on the requirement. Other nutritional requirements include water should be given at the rate of 30 ml per kg, sodium, chloride, potassium comes to 1 to 2 millimoles per kg, calcium and magnesium 0.1 millimoles per kg, and phosphate 0.2 to 0.5 millimoles per kg. The exact composition and infusion rates can be tailored depending on the patient needs. Coming to the how you initiate the tube feeding. So first and the foremost is placement of feeding tube. That is enteral feeding. Feeding tubes are inserted through the nares and advanced blindly into the stomach or duodenum. First, you should calculate the distance. Distance required to reach the stomach can be estimated by measuring the distance from the tip of the nose to the earlobe and then to the refied process. It typically comes to 50 to 60 centimeters. Once a tube is advanced, check with portable chest X-ray to verify the proper tube position. Common practice by pushing air through the tube and listening for vowel sounds is not reliable because sounds emanating from the misplaced tube in the distal airways or pleural space can be transmitted to upper abdomen, especially if the patient is sedated or intubated who do not cough when Ryle's tube enters the trachea. Coming to the placement of in the Ryle's tube, whether it should be placed in gastric or duodenum. Most studies showed that there is no difference in the risk of aspiration with gastric or duodenal feeding. The important thing is secure the tube properly, especially in the patient with CVA who may be irritable. Second important point is pick patient up. The patient should be sat up an angle of at least 30 degrees to 45 degrees to minimize the risk of reflux and aspiration. Third thing is starter regimen. So traditional practice is to begin the tube feeding at a low infusion rate, that is 10 to 20 ml per hour, and then gradually increase, advance to the target. It is called trophic infusion. It can be given as bolus depending upon the clinical case scenarios. And feeding should be done under strict aseptic precautions. Aspirate regularly for every 4 hours after feed to ensure that gastric residual volume, that is amount of fluid left over. So previous guidelines, they say that if, avoid feed if the gastric residual volume after 4 hours of feed is less than 200 ml. But the recent study, they say that up to 50 ml is acceptable and there are no risk of any regurgitation. The nursing staff should be adequately trained and strict monitoring is required during the feed. Fourth is use of prokinetics. If the patient is not tolerating the enteral feed, the patient is having any vomiting, then prokinetic agents can be given, such as metoclopramide 10 mg IV TDS. It is an dopamine antagonist, and important advantage is decreases the gastric residual volume by 30%. And it can be combined with erythromycin 200 mg IV every 12 hours. The action is it will stimulate motilin receptors in GIT and increases the motility. But one should be careful that the efficacy wanes over a few days. Coming to the what type of enteral feed we should administer. It depends upon the availability in the hospital. So the three availabilities are there. Hospital prepared feeds may be available, polymeric preparations may be available, or elemental preparations may be available. So most of the hospitals, they have hospital prepared feeds, which include recipes varying among hospitals, which may include hard-boiled eggs, milk powder, soya, maize oil, rice, sugar, and fruit juices. These hospital-based preparations are cheaper than commercially prepared foods. So what are the problems with this is there will be unpredictable levels of both macro and micronutrients, and moreover, they are not sterile. So they should be used only if commercial preparations are not available or not affordable. What are polymeric preparations? Polymeric preparations, they contain intact protein, lipid, carbohydrate, which require digestion before absorption. So to it, they will be added electrolytes, trace elements, and vitamins and fiber. Coming to the elemental preparations, these preparations contain macronutrients in readily absorbable form. In polymeric, there will be as protein, lipids, and carbohydrates, whereas in elemental preparation, there will be peptides, amino acids, lipids in medium chain, triglyceride, acids, and the carbohydrates will be in mono or disaccharide. They are easily absorbable. So it depends. So type of fluid, enteral feed administration depends upon the hospital availability, clinical condition, and tolerant, whether the patient is tolerant or not. Coming to the complications. What are the complications of enteral feeding? First is tube occlusions. So narrowing tube feeding tubes becomes occluded by protein precipitates that form when acid gastric secretions reflect into the feeding tube. So what are the preventive steps? Flush the feeding tube with 30 ml of warm saline every 4 hours after feed and use the 10 ml of water flush after medications are feed installed. If it is not relieving, then pancreatic enzyme like biocase tablets combined with soda bicarb tablets mixed with warm water can be used to flush the tubes. If they are not relieved, we should change the Rayleigh tube. Coming to second complication, regurgitation or aspiration. Retrograde regurgitation of feeding formulas is reported most commonly. Following measures are available for reducing the risk of regurgitation aspiration pneumonia, such as we can should feed the patient in head up position, 45 degrees, and then coming to the gastric residual volume, as already mentioned, residual volume of 150 to 200 are typically used to stop, but recent guidance show that residual volume of up to 500 ml do not increase the risk of aspiration pneumonia. For aspirating any regurgitation or aspiration, prokinetic therapy is an additional option. Coming to third complication, diarrhea. Diarrhea occurs in approximately 30% of patients receiving enteral feeding. The principal offender is liquid preparation. We prefer liquid preparations because it is easy to administer and blockage of the tube will be low. So why this liquid preparation will cause diarrhea? Because of their hyperosmolality and presence of sorbitol in this preparation, it may precipitate diarrhea. So if the patient complains of diarrhea, so discontinue this preparation. Coming to refeeding syndrome. Patients who are severely malnourished or have undergone a significant period of starvation are at a risk of refeeding syndrome. So the patient is not taking any feed for periods, then you start a feed, then these people they develop refeeding syndrome because starvation causes a loss of intracellular electrolytes secondary to leakage through though serum levels may be normal. So on institution and administration of carbohydrate, then there is insulin-dependent influx of electrolytes into the cells, which causes rapid drop in serum levels of phosphate, magnesium, potassium, and calcium. So if you are anticipating after feed any clinical manifestations of feeding syndrome, such as confusion, delirium, seizures, cardiorespiratory collapse, rhabdomyolysis, then refeeding syndrome, though rare, should be considered. So anticipating any risk of refeeding syndrome, the preventive measure is start with feed slowly at 100 calories per day, gradually increase depending on the clinical condition, how the patient responds for a period of 2 to 7 days. Finally, the mucosal surface of the bowel is constantly changing with new cells to replace the old ones every few days. And the force behind this dynamic response is the presence of food in the lumen of the bowel. So, removing of nutritional bulk from the bowel lumen disrupts the normal process of renewal in the bowel mucosa and makes us vulnerable to invasion by hosts of enteric pathogens that inhabited the bowel. So this is the one of the major advantage of enteral feeding over TPN, and it also means that eating as a physical defense mechanism against infection. That's it. Thank you.
Very good. It's very well planned, and the readings are very nicely given. Lot of details about what should be the composition. But only thing is, do all patients with CVA require nasogastric tube feeding? Mr.
All
Rao?
patients, we should start the nutritional therapy.
The first and foremost thing is we must find out whether there is any swallowing disability, dysphagia is there in the patient or not. Because if you have had experience in managing or seeing patients with stroke, uh, majority may have a good swallowing reflex present. So they may not need NG tube feeding. They can be fed orally in the natural way. So how to find out whether the patient, the question of course says that he is on NG tube feeding, but how to decide whether a patient has to be fed with a nasogastric tube or not? For which you can do
The
what
patient,
is called the swallowing test. How do you do the swallowing test? Any idea? So several tests that have been described. You can ask them to take a glass of water, plain water, ask them to drink, and if they are not having any cough, not no gurgling sound, if they are able to follow it with ease, then we can allow them to take other foods also normally. Or on the contrary, if they hold up, the water is being held in the pharynx, the gurgling sound is there, aspiration and coughing is there. That is the indication to avoid direct feeding and put them on NG or NJQ. Uh, so, for the amount of time, I will just quickly go through the preparation of the PPT that I have made. Of course, you have made a very much more detailed presentation of